and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Antibiotic Use and Antibiotic Resistance, Just the Facts. If you have a question about anything being discussed today, please call or email during our program. The email address and phone number are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access these materials. 1.5 continuing education credits have been approved for nurses, nurse practitioner pharmacology, and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses and nurse practitioner pharmacology, expiring on October 31st, 2019, and 2 years for social workers, expiring on October 31st, 2020. Let's meet our presenter. Teresa Fox is a Quality Improvement Advisor at the Alabama Quality Assurance Foundation. Welcome, Teresa.
Thank you. At this time, we're going to, as our introduction said, we're going to be talking about antibiotic use and antibiotic resistance, just the facts. I thank you for inviting me to speak, especially ADPH and Leanne Hickson. And during our presentation today, we're going to talk about the use of antibiotics and its indications or emergence of multi-drug resistant organisms. As an infection preventionist in Alabama, I have seen the rise of multi-drug resistance. I can remember the first time that we had a MDRO, which was methicillin-resistant Staph aureus, and I'm all sure that you're quite aware of that one. And it was a big deal. We all got real excited. Now it's an everyday occurrence, and it's more and more antibiotics are prescribed, and more antibiotics resistance develops, the more we're going to see multi-drug resistant organisms. During our presentation today, we're going to talk about antibiotic resistance, what you can do as a provider or a nurse to reduce the risk for antibiotics and reduce the risk of multi-drug resistant organisms. So we're going to talk about the describe the mechanisms of development. We're going to define the factors that contribute to antibiotic resistance, and we're going to describe the action steps that you can take to prevent them. So let's begin about what is an antimicrobial. Antimicrobial are a large group of medications that include antibiotics that we use to treat bacterial infections, antivirals we use to treat viral infections, and antifungals, which are designed to treat fungal infections, and of course antiparasitics, which are used to treat infections caused by parasites. During our discussion today, we're going to talk about antibiotics and their treatment for bacterial infections. But I do want you to remember that antifungals do develop resistance, and so do other groups of antimicrobials. So let's begin by looking at the past. In 1945, there was an interview done by the New York Times of Dr. Alexander Fleming, which you know he was the developer of penicillin, and he identified that if we were not careful about the use of antibiotics, that resistance would begin and we would be back to pre-antibiotic stages. So within 10 years of the development of penicillin, you were seeing wide-scale use in 1943. Also, in 2013, Dr. Thomas Friedman, which was the past director of the CDC, said if we're not careful, we will soon be in the post-antibiotic era. Although antibiotics have transformed the medical response to bacterial infections and rendered easily treatable many formerly deadly diseases, the mishandling and misprescription of these drugs have transformed the bacterial population such that many antibiotics are partially or entirely lost to the use of preventing infections. The problem is so severe that many experts believe that the value of existing antibiotic therapies over the next 100 years is now uncertain. However, some also believe with proper response to the current trends in antibiotic resistance, these drugs might be saved once again and used to treat bacterial infections. I know this graph is really hard to see, but I want you to say from this that, bacteria have not survived millions of years by not mutating and changing quickly to their environments. And the same thing happens when we introduce new bacteria. Bacteria, as we can see at this graph, penicillin was introduced in 1943 and became widely used. But if you look at the resistance pattern, there was already identified a penicillin-resistant Staph aureus in 1940. So there was not even introduced widespread before we already had developed a resistance. Next one to notice is in 1960, methicillin was introduced, and by 1962, they were already resistant bacteria to that antibiotic. For many years, the drug companies and antibiotics were able to surpass and keep up with the changing bacteria. But as fewer and fewer drug companies are looking at producing antibiotics, and antibiotics resistance is developing so quickly at a national level, it's becoming more and more difficult for drugs to keep up with the resistant patterns. So what affects the resistance in everyone? Antibiotics resistance threatens the use of antibiotics for all people at all ages. In short, antibiotics are essential in the treatment of some infections, but also can produce harmful side effects. And we're all quite familiar with what the side effects are: upset stomach, rashes, interaction with other drugs, and then, of course, the deadly diarrhea, which is caused often by Clostridium difficile. So, what is the forecast for the future? If you look at data right now, it says that 1 in 5 visits to the ED are related to adverse drug events to antibiotics. It is also the #1 reason that children less than 18 years of age show up in our EDs. So with this in mind, you can see how we have added consistently and expensive medical costs to the healthcare environment. These costs are estimated to be about $35 billion a year in excess costs due to antibiotic. This came out August the 6th of this year. And what I found interesting about this, you see Big Pharma back off superbugs, why 5 drug makers bailed on antibiotic research. So the article appeared in what is known as the Beckler's newsletter, and the article described how the 5 big pharmaceutical companies shut down their antibiotic and antiviral research projects for the development of new antivirals and antibiotics. And with the lack of research, and with at least 2 million people dying each year, 2 million infections from MDROs and 23,000 people dying each year, this is going to be a huge problem in the future. The pharmacy companies cited the lack of profitability for development of these drugs. They can make a lot more money by coming up with a new lipid, a new statin, or a new diabetes medicine, because you take those for long periods of time, probably for a lifetime. But when you do an antibiotic, 14 days is the maximum that you're going to take that antibiotic, so it's not profitable for them to spend the money to develop those new antibiotics. So antibiotics happens like germs and fungus develop the ability to defeat the drug or the antibiotic that is designed to kill them. Resistant germs are not killed, and they continue to grow within the environment. Infections are caused by antibiotic-resistant organisms are difficult to treat and sometimes impossible to treat. There are antibiotics that are not effective against all drugs. It costs increased follow-up with doctors. It has caused a more lengthy recovery time, and it's costly, and they are toxic alternatives. Some people think there is no side effects from taking an antibiotic, but that's just not true. Remember, we talked about rashes, diarrhea, and other things that are caused by antibiotic use. And there are two types of resistance that develop in an organism. It is through mutation or it's through gene transfer. They're really friendly little buddies, and they like to share their genotypes. This is basically what we have as the mechanisms for antibiotic resistance. I'm not going to go through these in depth, but I just want to tell you that, they do it through inactivation of the drug. They have mechanisms that could actually pump the antibiotic out of the cell, causing it not to harm or kill that organism. They do modifications of their drug proteins. Most drugs have to have a protein to attach to be effective. They do alterations of that. And there are defects or changes made in the cell wall that prevents the antibiotic from entering the bacteria. So the CDC has identified resistance as one of the most important public health threats in this country. Antibiotic use is the biggest driver in the development of antibiotic resistance. Infections that are caused by antibiotic-resistant organisms require treatment with more and more toxic and expensive antibiotics. And antibiotics resistance is often concerned in all healthcare settings, such as hospitals, long-term care facilities, physicians' offices, and home care. In order to be effective, for an antibiotic stewardship program to be effective and reduce the inappropriate, notice I said inappropriate, use of antibiotics, it must be at all healthcare levels. The appropriate use of antibiotics is often called antibiotic stewardship. And what is the purpose of those? It is to preserve the effectiveness of the current antibiotics that we currently have on the market. It is to extend the lifespan of current antibiotics. Remember, I talked about that methicillin was introduced in 1960, and by 1962, antimicrobial resistance had developed to methicillin at that time. It is to protect people from antibiotic-resistant infections, and it is to avoid the side effects from using antibiotics inappropriately. This is a state map, a U.S. map, that shows the antibiotic use across this country. So if you look at the graphic, it depicts that these are from outpatient settings only, and they are based on Medicare beneficiary that use and pick up antibiotics at community pharmacies. That is about 60 to 62% of all antibiotics that are used in this country. Most people think that, health care or long-term nursing is where we use the antibiotics. Not true. 62% of the antibiotics are used in the outpatient setting. So when you look at this, you can see that our nice little Appalachian belt, starting with West Virginia, Kentucky, Tennessee, Louisiana, and Alabama, are the highest users per 1,000 beneficiaries in the country. So we're really a sick bunch of people, or we're inappropriately using antibiotics. And we're going to talk about some instances as we go through about some of those tendencies for the state of Alabama. But if you look out west along the Pacific coast, the use is very, very low, with Alaska being the lowest. They're using 533 prescriptions per 1,000 beneficiaries. This is a closer look at the state of Alabama. And you can see we do have some areas that are green and some that are a little bit yellow, and this is all based on a heat map of the antibiotic use in Alabama. But you see all those little red dots? That is where we have high prescribing practices for antibiotics. In the areas that are in the red dots, that means that you're prescribing greater than 2.116 antibiotics for each 1,000 beneficiaries. this little graphic I wanted to share with you because this is also based on Medicare beneficiaries. And then you can see that the national and state antibiotic prescribing per rate per beneficiary. The data shows that Community A, which is a group in Alabama, up in the northwest corner, we have 1.9120 antibiotics per 1,000. That's nearly 2 antibiotics for every beneficiary in a calendar year. And this is significantly higher at 17% than the national rate of 1.583. That's not even looking at Alaska and some of the other lower prescribing rates. All Alabama cohort communities are prescribing at a higher rate than the national cohorts. So we have a long way to go and a lot for improvement. So what does Antibiotic Stewardship hope to do with this data and their uses? Let's begin by talking about preventing the misuse of antimicrobials, which will enable us to have the benefits of those antibiotics. And when I talk about misuse, I'm not talking about let's just lower the number of antibiotics that are given. We're talking about the appropriate use of antibiotics, which includes the right dose for the right infection or the right bug for the right duration. You know, we need to be careful about when we're doing that and how we're doing that. In order to have a successful antimicrobial stewardship program, we must provide education, which we're doing now, for nurses and providers, which are your physicians, nurse practitioners, and physician's assistants. We must use evidence-based guidelines for clinical assessment, testing, and we'll talk about testing a little bit later, and the treating of infections. We should use antibiotics only when they are clinically indicated, not because mama wants them, or mama thinks she needs them, or her urine smells bad, right? So we're going to talk about some of those things. You also have to have accurate assessment of the changes in condition. And this is where all healthcare providers can be part of the antibiotic stewardship program. Who does assessments of patients? Nurses are usually doing assessments of patients. So nurses are a vital element in the reduction of inappropriate antibiotics. You must have accurate, timely communication and documentation of all signs and symptoms and support that with laboratory results. You must assist as nurses and other healthcare providers, physicians or clinicians in managing symptoms of non-bacterial infections. So let's talk about some of the misuse of antibiotics. You know, I've said we need to be stewards and we need to take it seriously. So we can begin by saying taking antibiotics only when they're indicated. You know, we do have drug-to-drug interactions, we have medication side effects, and we have health care increased costs. So one of the ways that you can help is when you finish all your antibiotics as they are prescribed. You know, what do we all do? I go and get an antibiotic, I take it 3 days, and I feel so much better. I'll just put this up in the cabinet, and I'll take it the next time I'm sick, right? Well, the next time we're sick, we don't know how it was stored to, what was the expiration date of that antibiotic, so that may not be as effective. And we don't know what's wrong with us, so, you know, not all drugs are appropriate for all infections at all sites. So we need to be careful with that. If they give it to you for 7 days, you need to take it for 7 days, right? And take it timely. I found this really amazing that during this work that I've been doing, talking to patients, they don't always understand if a medication says twice a day, that's basically 7 a.m. and 7 p.m. They think twice a day, I can take it at 8 and I can take it again at 4. So as healthcare providers, we need to do a better job at educating our patients and their families about the appropriate use of antibiotics. The next one is one that clinicians will have to address, and that's the inappropriate of prescribing, such as for colds, viral infections, things that are not treated and an antibiotic will not help. We need to look at the use of broad-spectrum antibiotics when a narrow-spectrum antibiotic would be just as effective. That is a huge issue. The second thing, you'll notice I address nursing in Pacific. Use nursing assessment skills to accurately evaluate symptoms and communicate changes in conditions. You should encourage the discontinuation of the use of invasive devices such as catheters, central lines, IVs, when it's clinically appropriate. And I know we've heard, wash your hands, wash your hands, wash your hands, but it is still one of the major infection control practices to prevent the development and spread of bacterial infections. And I put this one in as just a side note because it is fall and it is the flu season. Always use standard precautions, which is gloves, gowns, and masks, as indicated according to the symptoms, whether they're coughing, whether they're incontinence. Be sure to use your standard of precautions appropriately and change dressings and use when you're performing tracheotomies and other things that we tend not to think of. So this one is, as we said earlier, unfortunately, no amount of antibiotics is going to kill the flu or a cold. It's just not. Those are viral infections. So if you have those, let me just give you a quick summation. I go to the doctor and I walk into the doctor's office, and there's three things that I want when I enter that office. I have sinusitis. I am hurt and I feel bad. I wanted a shot, which is usually Rocephin. I want a steroid that's going to make me feel better quickly. And the third thing I want is a prescription for an antibiotic. Did you know most sinusitis is viral? It is not bacterial. So we would have gotten 2 antibiotics for something that was not needed at all. The only thing that probably helped me a little bit might have been the steroid. It made me feel better quickly. But if you think of the normal process for a viral infection, normal length of duration is 5 to 7 days, right? So I'm sick day 1 and day 2. I go to the doctor on day 3. I get a Rocephin or a injection for an antibiotic, and I get a prescription, and guess what? Day 4, I'm feeling so much better. Well, in day 5, I feel much, much better. Well, you know, that is the normal course of a viral infection. It probably had nothing to do with the antibiotic that you got. You were going to fulfill the requirements for that viral infection. So for effective diagnosis and treatment and prescribing of antibiotics, we need to obtain a microbiology culture whenever possible to guide the appropriate antibiotics. You need to make sure that you're collecting those specimens prior to initiating the antibiotic therapy. And don't request antibiotics for viral infections. Asymptomatic bacteremia, and we're going to talk about that a little more in the conversation. And do not, for changes that don't ask for antibiotics for changes that are probably due to something other than a bacterial infection, such as a fall or confusion. There's a lot of things that cause confusion other than a bacterial UTI. So this one, we're going to talk about optimizing antibiotic use. So the first thing, you know, I said we need to get a culture, and when you get that culture, what you're looking for when they return those reports is the antibiotic susceptibility pattern for that specific organism. These are identified in the labs, and you can see the top graph shows the little disc that where the bacteria is growing right up to it is not resistant, and that drug is not going to do any good. But you see the big circles around those discs, that shows that that antibiotic is effective against that organism. So be sure to look at those sensitivity patterns. The one on the bottom is what is called a antibiogram, and I don't know if y'all how familiar you are with antibiograms, but they are very useful when you're looking at treatments for empiric therapy, because it will show you in your community, if I had an E. coli in a urine, which would be my best selection for drug for that organism. I encourage you, if you're in the outpatient setting or a long-term care or wherever, please contact maybe your hospital if you can't produce your own antibiogram, and ask for a copy of the local antibiogram. If that is not available, there is a statewide antibiogram, and this is where the snapshot's from, and they are divided up by community as well as healthcare setting. So it's a good source to look for just to get a general idea of what antibiotic you should be using. See? So now we're going to talk about the optimizing use. Upon receiving those laboratory results, you should always notify the prescriber and facilitate as much as possible an antibiotic timeout. So most people, antibiotic timeout, yep, that's a new term that's pretty new on the scene. And that's when you go in at 24 to 48 hours and you look at your sensitivities and you reassess whether that antibiotic is really necessary at that time. If the cultures are negative, please recommend discontinuation of the antibiotic. If they're positive, you should always provide the susceptibility report and encourage the use of a narrower spectrum antibiotic if it's available. And of course, assess whether you can de-escalate opportunities from an IV antibiotic to a PO antibiotic. To ensure antibiotics are continued, you must ensure patient information about the antibiotics is available. Ensure the appropriate antibiotic administration route is correct. And as we said earlier, do a antibiotic timeout, reassess the antibiotic therapy in 2 to 3 days after beginning. So how can nurses influence antibiotic management? You're going to be the person that's going to reassess that antibiotic therapy in 2 to 3 days. You're going to review the antibiotic therapy when your patient develops a new C. difficile, and you'll hear me call that CDI, infection. And you should always reconcile your antibiotics during all patient care transitions. That is a hard thing to accomplish in any healthcare setting. You use antibiotics only when clinically indicated. Avoid asking the providers for an antibiotic. Miss Jones's urine smells bad and it's cloudy. I think she has a UTI. Can we get an antibiotic? You know, remember, we're only going to do antibiotics for symptomatic UTIs. Practice excellent hand hygiene and follow recommended infection prevention and control practices, and use antibiotics as prescribed by the doctor, including taking the full prescription. Okay, as we said earlier, never take leftover antibiotics for a later illness. Never take antibiotics prescribed for another person. How often have we done that? Mom feels bad, she gives an antibiotic to Sister Jane, right? Stay at home from work, if possible, when you're sick. Get a flu shot every year. Cover your cough or your sneeze with a tissue, or use your sleeve near the shoulder or the elbow when you have to sneeze and no tissue is available. So I see we're going to talk about specific disease states, and here we are. We're going to talk about bacteremia in the elderly. There are 6 reasons why the elderly tend to be more susceptible to infections. The first one is their immune system has aged. It is not as effective as previously. Some research has said that we pass immunity from the mother to the baby, and then as children are exposed to infections, to other viruses and different environmental things, they start developing their own. So, you know, babies get real sick, and then they start to kindergarten, and guess what? It's a new environment, and they start all over. Because all those kids that are in that kindergarten class bring all their germs, and you're carrying your germs, and they just kind of a little mixed pile here, so everybody gets sick. But, you know, you go through, and if you notice, as the child gets older, they get less and less illnesses. And about 12, you have a full set of immunities, you know. And I'll just throw this in. That's the reason hospitals set age at 12. They ask you not to visit, is because you should have, below that, you do not have full set of immunities. So anyway, you rock on, and about age 30, you've got all those nice immune system, you don't get sick, but you know, at age 30, the research shows that your immunity system becomes weakened. And as you progress, it becomes weaker and weaker and weaker. So it's not that you've forgotten what you have, your body just does not react as quickly, and antibodies are not as effective. So time you get about 65, some research said you're down to about 10% of your full active set of immunities. Therefore, you see why the elderly get sicker quicker, right? So as they progress, it gets less and less. Also, the skin in the elderly is just like ours. It is our first line of defense against infection, but as you age, the skin becomes thinner and thinner, and therefore you get more micro tears, you get skin tears, allowing bacteria to get into places that it doesn't belong. The elderly are usually less hydrated, especially their skin, which we already talked about was one of their major defense mechanisms. Many elderly retain urine, which increases their likelihood of a urinary tract infection. They don't empty their bladder as well as they used to. The elderly have decreased ability to cough up secretions. You know, we can hack pretty hard and up comes a lot of stuff, but the elderly does not have that same mechanism to cough that up. And the use of medications that can suppress the elderly's ability to fight infections are often present. So, when we talk about UTI infections, UTIs are the second most commonly reported infections in the community and in hospital adults over the age of 65. It is only preceded by respiratory infections in their occurrences. They account for over 1/3 of all infections reported in long-term care residents. Just remember, the treatment for UTI should be reserved for symptomatic UTIs only. So we're going to look at the prevalence of asymptomatic bacteremia, and you're going to see I say that as ASB. It increases your risk, or the rate, from 1 to 2% per decade of life. So in the community, men have up to a 19% chance of having a ASB at all times. Women, that's about 16%. But men that are over the age of 80 are 20% or more are going to have consistent asymptomatic bacteremia. In long-term care, those statistics are a little bit higher. Women have a 20 to 50% chance of having an ASB, and men are from 15 to 40% likelihood to have an ASB. So we all say, oh my goodness, they have WBCs in their urine. So does that really differentiate a ASB from a symptomatic UTI, which I'm going to call a SUDI? It doesn't. No. The presence of pyorrhea is not a reliable indicator of an infection. ASBs and symptomatic bacteremia both provoke an immune response. The increased inflammatory markers in the urine, which includes your pyorrhea. WBCs are present in the urine in 78% of people with diabetes. And up to 90% of the elderly nursing home residents have pyorrhea with or without bacteremia. So we see that just because you've got WBCs in your urine does not mean that you have symptomatic UTI. So why is ASB so prevalent in the elderly? One, in women, you have a decrease in the estrogen levels that change the pH of the vaginal flora. There are anatomical changes such as prolapsed bladders or enlarged prostates that make it difficult for the elderly to empty their bladder. And of course, you have the increased incidence of diabetes in the elderly. You have cognitive defects. You have functional impairments. And then, of course, we have Foley use, a lot more prevalent in the elderly. So, is there benefits for treating ASBs? Probably not, except in the cases that I outlined: pregnancy, surgery involving the urinary system, or renal transplants. According to a randomized clinical trials done by Cochrane and a meta-analysis, they looked at 9 different clinical trials with a total number of participants of 1,614. They compared the outcomes in adult patients with an asymptomatic bacteremia with those that were treated and those that were not treated. The findings were there was no difference. There was no development of a CDiff. There were complications. There was no complications, including pyelonephritis or bacteremia, and there was not an increase in deaths. But what they did find was that those that were treated had more adverse drug events than the ones that were not treated. So why MDROs in the urine? The repeated exposure to antibiotics increase the chance of following up infections with MDROs. There was a cohort study in the Journal of Critical Care in 2016 that showed in long-term care patients, 26% of all urine isolates were resistant to Bactrim. 40% were resistant to Levaquin. So when we look at treating asymptomatic bacteremia, you need to be careful. There is the risk of development of C. difficile infection, the development of multi-drug resistance. There is the side effects of taking those antibiotics, and of course there is the increased cost for the providing and treatment of those antibiotics. So, everything has a balance. So what is the hazards of misdiagnosis when the patient really did have a UTI? Complicated UTIs, which means it extends beyond the bladder, is the most common cause of sepsis in adults over the age of 65. UTIs also cause approximately 10 to 30% of all severe sepsis or septic shock. So it is important that we do good clinical assessment and diagnosis of UTIs. And 28 to 50% of elderly patients with septic shock will die. Those are staggering numbers, and they're eye-opening. So what you have to do, it is a balancing act. You must do the things that we can and look for unintended consequences. We must look at prevention. What can we do to prevent the UTI? We can certainly reduce the use of Foley catheters. There is a group of prevention measures that is called the CAUTI bundle. You must only treat SUDIs or symptomatic UTIs, And this may be a new term, diagnostic stewardship. And we're going to talk a little bit about what diagnostic stewardship is. And you should look at the unintended consequences of any change in prescribing or assessment. So let's take a quick look. I'm not sure how many of you guys really use Foley's in your practice, but let's look at those things because they are a high risk for the development of a UTI. First, insert using aseptic technique only for the appropriate indications and leave in only as long as is needed. Be sure that you're using a securement device. Be sure that you keep the bag below the level of the bladder at all times. Ensure that you maintain a closed drainage system. Don't be going in and out of that bag. Leg bags in long-term care, I would like to say I have a staunch, this is what you need to do, but there's really no consensus in the literature about that, so just make sure that you have a policy if you're using leg bags in long-term care, how you're going to use them. Avoid irrigations. Maintain an unobstructed urine flow. And how you're going to do that? You're going to keep it free of kinks and dependent loops. Remember, we're going to keep it below the bladder. And you're going to use a separate bag regularly used to separate. When you empty the bags, make sure that you do separate containers for each patient. Don't be piling them all together. Consider alternative methods, such as a condom catheter or external female catheters. I know people say, oh, those don't work good, but there have been a lot of progress in the area, and there's lots of vendors that are providing some really good products. So if you're interested, be sure to look out on the internet and just put in catheters external, and you'll be able to pull them up. Do not change catheters or bags on a routine interval. Perform audits and provide feedback to the staff on how well they're doing. That doesn't mean return demonstrations during yearly skills fair or upon hire. It should be audited during their daily task when they're performing it for patients. Change out long-term catheters prior to culture collection. And I'll explain to you in a minute why that's really important. And when we talk about long-term catheters, we're usually talking about catheters that have been in place for greater than 2 weeks. You can also teach patient and families to practice good hygiene. If that's healthcare providers' number one way to share bacterial from person to person, the same is true for patients and their families. So be sure to teach them the appropriate hand hygiene system. Promote adequate hydration in all the elderly patients. Encourage prompted voiding, and encourage proper hand hygiene, such as don't leave them wet or dirty. You should encourage mobility as much as possible. And then this one I've seen a lot is use of cranberry capsules is a controversial practice. There was a randomized clinical trial in 2012 that showed a decrease in bacteremia and pyrethria in females in a nursing home residence. But they did a random study in 2016, and it showed no statistical significance difference when it was compared to a placebo. So that's just for your own edification. Bacteremia risk increases from 3 to 10% per day when a catheter is in place. 100% of all patients in long-term care will have urine that is colonized with bacteria. And we're going to talk a little bit about biofilms. And biofilms can form as little as 3.5 days on a catheter. And the biofilm organisms, which is the coating on the outside of the catheter, can ascend from the catheter in 1 to 3 days in the bladder. So that's the reason it's so important to only use catheters when they're absolutely necessary. So we're going to treat symptomatic UTIs, and I agree. the detection in the elderly is very, very difficult. They do have significant cognitive defects. They have chronic genitourinary symptoms such as incontinence, frequency unrelated to an infection. There are nonspecific symptoms such as anorexia, confusion, and a decline in their abilities to perform ADLs. And in the elderly, fever is often absent or it is diminished. So in order to do that, you need to make sure that you're getting a detailed medical history on each one of those patients. Use an objective pain scale and palpate the bladder area, looking for pain. Involve others such as PCAs, patient care assistants, other family members in the home. They spend the most time with that patient, and they can detect subtle changes in that patient. So use all your healthcare providers and families to help assist you with identifying symptomatic UTIs. So now let's take a brief look at Clostridium difficile, or CDI. So Clostridium difficile is an anaerobic organism that lives in the guts of most people. Okay? When CDI is identified, it is almost always related to antibiotic exposure. In 2015, there was a study performed, and 500 million infections per year, and there was 15,000 deaths directly attributed to Clostridium difficile. The medical costs over that 5 years in C. difficile were astronomical. It has been predicted if we can reduce the number of C. difficile infections and contain it, then we will have significant decreases in antibiotic costs and medical costs to treat C. difficile. CDI is the most common cause of acute infectious diarrhea in long-term care. It is more likely to be admitted to a hospital from long-term care, and you have significant 3-month mortality when the patient has had C. difficile infections. This is a beautiful little graph that was done by our Alabama pharmacy. They borrowed it, but what they did do is we have divided antibiotics for their risk of C. difficile. You notice that you have a high risk for C. diff, you have a medium risk for C. diff, and low risk. And the antibiotics that fall into those groups are identified. And I will say, I said that most cases have direct link to the antibiotics. There are 2 groups of antibiotics that are most closely associated. And it's your 3rd and 4th generation cephalosporins and your fluoroquinolines. So when you look at the high risk in Alabama, the ones that are bolded are the ones that are most often used. And you notice, looky there. There is Rocephin, number 2 on that list, which is a 3rd generation cephalosporin. And you see we got ciprofloxacin and we have levofloxacin, which are both corflinolins. And so we are using those antibiotics very much. And if you saw some of the graphs from our data, here's our fluoroquinolone use in the state of Alabama and the nation. Do you see that dark little blue section down through there? We're one of the highest providers in the community of fluoroquinolone. And I will tell you, most of it is Levaquin. We use a lot of Levaquin in the state of Alabama. And here is our cephalosporin rates. We are not doing any better with our 3rd and 4th generation cephalosporins than we are doing with our fluoroquinolones. So you can see from these graphs that we have a long way to go in reducing the use of antibiotics in our state. So now we're going to talk, remember I said respiratory infections was number 1, just above UTIs in long-term care for the number of infections. So what are we talking about when I say respiratory? We usually call them upper respiratory tract infections, and abbreviated as URTs. Those are colds, laryngitis, pharyngitis, tonsillitis, sinusitis, and the one that gets me, acute otitis media. Okay? Lower respiratory infections, which are LRTIs, are your acute bronchitis, bronchiolosis, pneumonia, and so forth. Respiratory infections, 1/4 of all visits to a general practitioner in each year is up for respiratory infections. 60% of all those antibiotic prescribing in general is for upper respiratory or RTIs. And at least 30% of those antibiotics were unnecessary. A 10% decrease in the appropriate prescribing in the community could result in a whopping 17% reduction in the number of Clostridium difficile infections that are identified each year. This one I love because this is where they looked at upper respiratory infections or respiratory symptoms, and you'll notice that they were given, some patients were given an antibiotic, and some were giving a sugar pill. And look at the pattern of feeling better, days of illness. They're basically the same. Remember when I talked about that you probably were going to get better just because you had a viral infections, and the normal course of illness is 5 to 7 days. Look what happens in about 5 days on this graph, right? So these self-limiting illnesses are going to go away whether you have an antibiotic or not. We've all seen this one. Is it a virus or is it a bacteria? This is great patient education and provider education because it talks about when you should actually get an antibiotic and when you should not get an antibiotic. And there's that little group in there called maybe, and those you have to be very careful about whether you prescribe an antibiotic or not. And it will be based on clinical assessments in that point. So let's talk about education. We must educate residents, families, patients, and visitors. We need to educate them about infection prevention and control and let them know what the difference is between a hospital infection control practices, what's different in a nursing home infection control practices, and how you look at infection control in the community or the home. Contact precautions are generally implemented for all patients known to have antibiotic-resistant organisms while they're in the hospital. And the reason for that is because people in the hospital are generally more sick and they're more vulnerable. Frequent presence of invasive devices, a lot of IVs, a lot of central lines, and a lot of catheters. You must be able to assure family members that you are providing appropriate care to their loved ones. So how are you going to do that? Through education. Take the time to explain to them why it's important that they practice good hand hygiene, getting their flu shots, making sure that their eating environments are clean. You know, if we all get most infections, it's through the mouth or the sinus. And, you know, literature shows that the average person touches their face and their mucous membranes from 300 to 500 times a day. So we have a lot of opportunities to infect ourselves, and that's how most of us are going to get it. We cough, or we touch surfaces, and then up to our face we go. And that's how you're going to get it. But when you talk about MDROs, I want to just point out, you know, most of us that are doing surveillance for, say, MRSA, you're getting cultures from the nose, but there's 3 places that MRSA actually isolates. It's in the nose, underneath the arms, in the armpits, and in the genitalia areas. So as a healthcare provider working in infection control and acute care, I will tell you most of the cases that we have seen in the last few years are not in the hospital, new cases, or in long-term care. They're coming in from the community. So it is quite prevalent in the community. That horse is out of the barn, but there are other serious multi-drug resistant organisms that are on the horizon, such as CREs, C. difficile we talked about, vancomycin-resistant enterococcus, or VREs. You need to be conscious of those things and make sure that you are providing good infection prevention and control measures when you identify those organisms. So we have talked about antibiotic stewardship, and the CDC has come out with the 7 core elements for antibiotic stewardship, and those are the antibiotic stewardships for acute care, critical access, and long-term care. There is a different set that only consists of 4 for outpatient, but we're going to stick mainly to the core elements. What I want you to know is that you don't explicitly see a nurse's role in antibiotic stewardship and how to achieve that. But if you look at these elements closely, what you do see is that nursing is involved in nearly every one of those. So the core elements are, you must have leadership, and the leadership is there to provide staff, financial, and informational technology to your antibiotic stewardship programs. The second in the wheel is accountability. You have to identify a single leader in the area to head up antibiotic stewardship program and be responsible for outcomes. Not just that process measures are implemented, but what are your outcomes? The third one is drug expertise, and what you would need to do there is identify a single pharmacist that would be responsible for working with the others to implement and use drugs or antibiotics appropriately. The third one is action. Make sure that you're implementing evidence-based interventions that can reduce inappropriate use of antibiotics throughout your project. You must do tracking, which is monitoring antibiotic prescribing and resistant patterns in your practice. Reporting, you can monitor and you can track and you can look at all kinds of things, but no improvement is going to happen until you provide feedback to the people, such as the doctors, the nursing, or relevant staff, on how well you're doing and what you can do to improve your processes. And the last one is education, and this is a key part of for our state especially, is education for providers and clinicians along with patients and family. Remember at the beginning of this presentation I talked about what are the 3 things I want when I go to a physician's office, right? I got something that's probably viral, but I want a shot, a prescription, and a steroid. Encourage people to use things that are non-medicated interventions, such as using saline up your nose or taking fever, taking something that helps you cough, those kind of things. So we talked about earlier about diagnostic stewardship, and I just want to throw in a good little key for this. Diagnostic stewardship is ordering of tests that is guided by careful clinical evaluation, recognition of clinical syndromes, and the estimation that the pre-test likelihood will predict the condition that you're looking for. That was in JAMA in 2017. So what does that all say? You need to reconsider current practices as far as way you use diagnostic guided therapy versus empiric therapy. So what are we going to do? The next thing is we're going to modify ordering, performing, and reporting of diagnostic tests. 1, test only when symptoms suggest, say, a urinary tract or infection, or if it's symptomatic in accordance with the guidelines, which are pregnancy, urological surgery, or renal transplants. Include, this is a note to laboratories, include interpretive results such as multiple organisms present indicating likelihood of contamination. We do not need to be treating contamination, and we could have a whole day on how to collect specimens, but we'll talk about that some other time. Remember that patient safety is all of our goals. We cannot provide unsafe care for our patients. 1, as we change any care delivery, a potential for unintended consequences and harm exists. So what could those be? Such as, I decide I'm not going to treat a symptomatic bacteremia, but I have not implemented a system for nursing clinical assessments. We have not implemented appropriate testing. And one of those I'm going to talk about a little bit right here is for C. difficile. You know, C. difficile is a serious infection. But when we're treating for C. difficile, we need to make sure that it is C. difficile or Clostridium C. diff. 1, you're going to collect a specimen, and most people use the guideline 3 unformed stools within a 24-hour period. Usually they will look at previous antibiotic administration. And then when you talk about those C. difficile specimens, they should be taking the shape of the cup. That is a definition from CDC of an unformed stool specimen. If it's a glob in the middle of the cup, that's not an unformed, that's a loose stool. But make sure that you're hitting the right criteria. And when you send that off, make sure that you send it off promptly to your lab. And you need to know what kind of testing. Is it a PCR method? Is it an EIA method? What method is that laboratory using to identify C. difficile? Toxin. Remember, toxin is the one that causes the C. difficile. And you need to send those off and make sure that those are on your alert list. If they get a positive, they let you know so that you can get those patients isolated or get preventive measures in place. So once the test comes back, and if it's negative, there used to be an old rule that you did them times 3, stool collections times 3. Well, that has gone by the wayside as more and more sensitivity and specificity have been identified for testing. So now most labs are refusing what they call formed stools or inappropriate specimens, and if it's been less than 7 days, repeating the test. I have seen some research that says that every time you repeat that test, you could pick up colonization for C. difficile. Some people say up time you get to the 3rd test in times 3, you have a 60% chance of having a false positive. You know, just because you've got C. diff in your gut doesn't mean that you have infection with C. difficile, and that's what you're looking for. Be sure that you're not testing patients that have known causes. Remember, the definition says diarrhea with unknown causes, right? And this in routine cases. But if you've given them a laxative, or if you're doing tube feeding, is it uncommon for them to have diarrhea in those circumstances? Probably not. So make sure that we're not treating patients for C. difficile that doesn't need treating for C. difficile. And as we talked about, diagnosis, that's another circumstances that you need to look at the consequences and weigh and make sure that you're using your clinical knowledge appropriately. You need to closely monitor Diagnostic Stewardship. Are we ordering when we should? And as changes are made in that process, make sure that you're limiting the consequences that occur. So you need to track it and follow it and monitor what's happening. Tests should be targeted by stewardship, should always be available to providers by special request or in certain circumstances, regardless of what your policies say. We have antibiotic stewardship. Remember, it's always the right drug for the right bug for the right duration. I'd like to throw one other little plug in here if I can. In July of 2017, CDC released the new antibiotic stewardship guidelines. They are available on CDC's website, and some of the antibiotics that were like 14 days have gone to 10, some of the 10 have gone to 7. So antibiotics that you're using, be sure that you're checking the CDC website to see have they been a change in the dosage or the duration of those antibiotics. It's coming up quickly. One of my last plugs is for U.S. Antibiotic Awareness Week, which is November the 12th through the 18th. This will be sponsored by CDC, so I encourage you to reach out to the resources that are available on CDC and celebrate. And this is a great time to educate your providers and your staff about antibiotic resistance and how to improve patient safety through the use of appropriate antibiotics. And then at the end, I hope these are beneficial to you because I've used a lot of terminology and I'm not sure how much of it you're aware of, but we go through and we define what is antibiotic resistance. We talk about what is bacteria. We talk about broad-spectrum antibiotics, and these are antibiotics that we're really trying to target because they are wide range. They cover a wide range of bacteria. They are often more toxic and cause more side effects than narrow-spectrum antibiotics. And broad-spectrum antibiotics may be prescribed to treat an infection when the causative organism is not yet identified empirically, and the antibiotic can be targeted to other organisms once the lab results are available. So remember we talked about narrowing our perspective on broad-spectrum antibiotics. And unfortunately what I see happening is, in all healthcare settings, we go with a broad-spectrum antibiotic for empiric treatment. We get our culture and our sensitivity back, but this antibiotic's working, we just won't change it. We really should be encouraging providers to de-escalate those antibiotics to a more narrow antibiotic whenever possible. You heard me talk about Levaquin earlier. There are places in the state of Alabama that, you know, most UTIs in the community is caused by E. coli, which is a normal enteric organism. It just happens to get into a place that it shouldn't be. And we would get them to the hospital, and the organism would be like, in some places, 80%, 70% resistant to fluoroquinolones, which is usually Levaquin. And we would have to go to much more costly and to get an effective antibiotic for that UTI, because they wouldn't have been in the hospital if we had been able to treat it at the community level. So the resistance to those organisms, our fluoroquinolones in third and fourth generations, are not only linked to C. difficile infections, they are linked to having to take more and more high-powered drugs when you do get to the hospital. It would be great if we could limit those broad-spectrum antibiotics so that when I went to the hospital, I would have a better choice of what antibiotics would be effective against the disease that I have. Colonization, you know, when I talk about asymptomatic bacteremia, that's usually what it is. It's the presence of bacteria or other microorganisms without signs or symptoms. We all know what infections are. We know what mutations are. We talked briefly about narrow spectrum antibiotics. Normal flora bacteria, we're not going to go into that, but we all know that that exists. And we talk about viruses, which are microscopic particles that can reduce only inside a cell of a living organism, and viruses cannot be killed by any antibiotic. We have a list of resources here at the end, and I'd like to say a special thank you to Amy Stevens at Crestwood Medical Center in Huntsville, Alabama, for helping me get some of this research together. And now we're close to the end, and I'd like to know, does anybody have any questions or thoughts about something we would like to talk about?
This is your opportunity right now. The email and the phone number are both on your screen at this moment, so email us, give us a call if you have any questions for us. While we're waiting on folks to send us some questions in, could you hit the high points for us again? If I listened to nothing else, if I take nothing else home from this, what are some of the most important points that you would just want to hit them again, just to make sure we really hit home this message?
I think the overall message is antibiotics are a issue for all of us, not just for healthcare providers, not just for staff, not hospice, not long-term care, or for home health. It affects all of us. If we have antibiotics and we give our children antibiotics repeatedly, as more and more antibiotics are given, the resistance increases. As resistance increases, it becomes harder to treat. So we need to look now at what we can do to prevent the inappropriate use of antibiotics. And as a user of health care, I need to be careful about when I am demanding antibiotics, because talking with physicians across the state, they feel a lot of pressure from the patients to prescribe an antibiotic. I really don't think they need it, but their satisfaction with their office visits are very low. Now, I don't know if that's an assumption just by physicians, that that's what they perceive, because it does make the office visit a lot quicker if you can give them an antibiotic instead of sitting there describing to them why they don't need that antibiotic. So we need to be careful with that. And as healthcare providers, we need to be the voice that's out there, because a lot of people depend on you for their general information. I get calls all the time from people who say, so-and-so and so-and-so is wrong with me. I have a call, I have this. Do I need to see a doctor? Well, we're not going to tell whether they need to see a doctor or not, but we can ease the pain, that I call it, in non-threatening situations. If I go to the physician's office and I'm sick, you mean I'm really sick, don't start telling me why I don't need an antibiotic. I want that antibiotic and I want it now. So we need to do non-threatening education for patients and families. Start educating them on why it's important that you don't get antibiotics, what the future for antibiotics are, and what's your future if you inappropriately use antibiotics. I always go back to where smoking was 40 years ago. We know smoking's bad for you. In the late 60s, early 70s, people didn't know it was killing them to smoke, but we did lots of campaign, and we did a lot of education about smoking and how it affects you, what it does for you. But, we have the impression that antibiotics, I'll just give it to me, it's not going to hurt me. Well, it can hurt you, and it does hurt people in the future. So what you do as a patient not only affects you, but it affects your entire community and your family, because if you develop that resistance, you easily share it with your family. And I use the story that, you're healthy and you're young. Grandma's not so healthy and young. You get MRSA, and you take it home, and you share it with Grandma. Well, Grandma falls and breaks her hip. Now, she has to go to the hospital and get a hip replacement. And during that procedure, You know, most surgical site infections come from the patient, not something that happens in the OR, not something, it is based on their own patient flora. So now Grandma gets an infection in that hip, and she ends up with a replacement antibiotic. She has to go back in, have it taken out, the prosthesis. She gets an antibiotic disc to treat the infection. You know, those are long, hard treatments, and therefore it was detrimental to her health. She's not as well as you are, so you need to make sure that you're doing the correct things to protect you, your family, and your patients, because I can't spread it to you if I don't have it myself. When I worked in the hospital, I'd always tell them, you know, I really don't care who you're protecting. In the long run, you're protecting my patients if you're doing the right thing. So just make sure that you're taking your antibiotics appropriately and encourage others to take them appropriately.
I think we have a question here in the room.
One thing piqued my interest, you mentioned that when you go to the doctor's office, or I think this is what you said, that possibly part of your examination should include lab work for them to determine whether it's viral or bacterial?
No, I was really talking about UTIs.
Okay.
Yeah.
Okay.
And most people are going to be able to make a clinical assessment, whether it's a respiratory infection or, you know, they may do a chest x-ray looking for pneumonia. And I'm not saying, well, people say, oh, you want to just decrease the antibiotics given. No, the main goal is don't make sure that you're doing appropriate, not inappropriate prescribing of antibiotics. That we're prescribing antibiotics when they're needed and clinically assessed and infection was identified.
Can I ask you another question about the antibiograms? Is it true that your antibiogram can be different based on your facility? There's different resistance at different places?
That's true. Yeah, you remember I said it would be best if you could contact your local hospital, or if you're a nursing home, have your own antibiogram, because you remember when I talked about schools, how when you went into the school, that little classroom has its own environment. So do healthcare settings. What my environment at Hospital A is may not be the same as the Hospital B's environment. And you also got to remember what's feeding the patient population is feeding A is going to be probably different from what population is feeding Hospital B, and they all come in with their own set of organisms. So you really need to look closely in your area, and unfortunately a lot of places do not have enough cultures to be able to do their own personal antibiogram, which would be great, would be the best thing that you could do. But if you could get, say, a local area one, that would be better. And then if nothing else is available, we do have a statewide antibiogram. And when you look at our state versus other states, you can see that there's a difference in the susceptibility of those organisms. I wished I had included, there is a website, and I'll try to send it to Leanne, that you can go out on the internet and put in your zip code, and you can say, I want to see the drug-resistant bacteria rates or percentages, say for a 100-mile radius, and it'll tell you what is your percentage. I remember MRSA in most of the state of Alabama is about 50-50. 50% are resistant and 50% of Staph aureus is not. It includes VRE. It includes I think CRE is on there too, but so you can get a good, clear picture of what is your resistant patterns for your local area. And I find it really interesting. Most people won't find it too interesting, but I'll send it to Leanne, and she can include it when she sends out some information that you can look at your specific location.
I have one more question.
Okay.
It's a very uneducated question, so I apologize now. You kind of equated our information on antibiotics and where we are with smoking when we were in the 50s and the 60s. So I know there was a whole lot of promotion about how smoking was killing us. Mm-hmm. Is the antibiotic resistance information. Is this something that we could or should start at the pediatric level? So when kids are old enough to understand what medicine is and why it's being prescribed, should we start educating our children then with their parents in the room, and so we're educating both generations? Or do you have an opinion on that at all?
Well, Lois, like everything else, I have an opinion about everything. Yes, I think that education needs to start. And, you know, let's just say that pediatrics do a much better job than with older children. How many times have you taken your child to the pediatrician and it's like, it's just a virus, not going to give you an antibiotic, right? And we understand that as parents, but somewhere we lose that connection that, oh, now I'm the patient and I have a viral infection, but I want an antibiotic. So when I talk about smoking, you know, they didn't know that it could cause bad health. Well, now we've got to educate our consumers about the risk for taking an antibiotic, just like we did for smoking. I would encourage practices, clinics, to put up information in what I call the non-threatening situation, so that you kind of till the soil as an old farm girl until you can't plant cotton, until you till and you fertilize that field. And so you got to set the stage so that when our patients go to their physicians, that physicians don't feel that pressure to prescribe an antibiotic when they don't think it's necessary. I will tell you from talking to physicians, their feelings are that they come to me, I don't do a prescription for an antibiotic, so they go down the road to another provider until they do get a prescription. So, you know, am I going to lose that patient in the meantime because I didn't provide an antibiotic? So it's education. I know that Leanne have done some public announcements, but as healthcare providers, we need to be on the front teaching what patients need to know. And myself as a healthcare provider, we have not done a very good job, you know, educating our patients about what is appropriate antibiotics. Just remember when I talked about how patients don't understand how to take medications. Well, nothing against pharmacies, but how many times do you go into a pharmacy, they hand you a prescription, it's got clipped on it 3 pages, a little bitty tiny print, and they say, do you have any questions? Well, number one, I'm old and I can't see it, and you can tell I squint a lot trying to see that screen. Second of all, I haven't had time to read it, so I don't know if I have any questions or not. And third, I probably am not going to read them anyway. So we need to give very concise information, and that begins in the community at the pharmacies. You know, take all the prescription, make sure that you're taking it on time, and I say twice a day, this means this, take it with food, you know, if you have a fever, this is what we need to be doing general education. You could have a PhD in chemistry and not understand and be illiterate in healthcare. It is a totally different language, and we as healthcare providers need to understand that and talk to our patients and families, not with big words, but with words they understand, so that we're setting that expectation when they go to the doctor's office that I'm not always going to get an antibiotic, but he's not giving it to me because it's in my best interest.
Teresa, back to the healthcare workers, you mentioned that the right drug, the right route. Can you elaborate more on about the correct route? So if it's a nurse looking at the information, is it up to her to determine if it's IV, PO? How does that work?
No, that's a provider, but you certainly can look at the route and look at your clinical assessments and make recommendations. You know, hey, this patient has so-and-so, we could change this from an IV to a PO, and it's just as fast. You're able to do those. That's what I'm talking about, assessing and as much as possible helping physicians move from IV to PO.
All right. We don't seem to have any more questions, so thank you so much for coming. I feel like I learned a whole lot of things today. It's very, very interesting. I appreciate you presenting for us today. As a reminder, continuing education credits are available for today's program. Nurses and nurse practitioner pharmacology qualify for 1.5 contact hours expiring on October 31st, 2019. Social workers for 1.5 hours expiring on October 31st, 2020. In order to receive credit, you'll need to complete and return the sign-in sheet and evaluation for watching the entire program. Have a great day. We'll see you next time.